Hey guys, Angela Cornelius back with Matt Willens again. So let's talk about some more endocrine knowledge.
Woohoo!
So it's kind of the same format that we've been using. We'll talk about a case, and then Matt and I will talk our way through it, just kind of stream of consciousness. What are we thinking? The things that we're seeing, what is it making us think about?
You are dispatched to a 33-year-old patient with weakness, fatigue, and confusion. Upon arrival, your patient is noted to be laying on the sofa, stating that he is weak and he cannot get up. His vital signs are a blood pressure of 88/53, pulse rate of 115, respiratory rate of 22, and his temperature is 97.8. His forelead is noted below.
So seeing this case, what's your first thoughts and what's your differentials on this?
Okay, right. So we've got nausea, we've got vomiting, we've got weakness. My first thought is I want more history, right? Did they have a head injury recently? Or again, did they have a shunt, right? Always have to think about, did they have something implanted in their head? Or was there a sudden onset of a headache, like a thunderclap headache? Does he have a subarachnoid hemorrhage? Moving down his body, right? He's got weakness and fatigue and confusion, so hypothyroidism, right? The thyroid gland definitely controls like ups and downs, so is that really down? He's got low blood pressure. He's got tachycardia. So does he have a cardiomyopathy, right? Is it like a cardiogenic shock where the heart's just not pumping well enough? That could count for that. So you look at the rhythm strip, right? He's got some peak T waves, maybe a little bit of a widening of the QRS, probably still within criteria, but wider than what we're used to seeing. That makes me think like, could it be something electrolyte-wise? The nausea and vomiting itself may actually be causing dehydration and leading to an AKI and electrolyte abnormalities. In particular, potassium's always the big one we worry about. And then systemically, you've got the low blood pressure and the tachycardia, right? Everybody's favorite diagnosis, sepsis. So you always have to think of that again. It can kind of act like a lot of things.
So what other information do you need from this?
So first off, I want to know his past medical history if I can get it. A recent trauma history. Does he have a history of head bleeds or anything that's happened in his head? Does he have a shunt? Did he have hydrocephalus? Any of those type of things. Does he have a headache? And then I want to know what was the description of that? How was the onset? How was the quality of the headache? Thyroid problems, right? Has he ever been diagnosed with anything? And then I might even follow that up with, do you have issues with feeling really, really hot when everybody else is cold, or the vice versa where you feel really, really cold and everybody else is hot? Does he take medications and is he compliant with them? History of heart problems, any chest pain, shortness of breath, viral type illnesses, right? Because viral illnesses can lead to a myocarditis that could be causing these symptoms. And then fevers and then wounds, right? Does he have a wound somewhere? Does he have a toe that's falling off that he just forgot to tell me about? Those type of things.
He states that he has been having nausea, vomiting, and diarrhea for about a week. Since then, he has become so dizzy and fatigued that he's not able to get off of the sofa. He has developed such severe back pain because of this that he is unable to walk without help. Your patient's past medical history is hypothyroidism with repeated syncopal episodes, idiopathic tachycardia, idiopathic hyponatremia, hypersomnia, depression, anxiety, and social phobia, along with personality traits of OCD. Your physical exam reveals a male who appears malnourished with very tan skin.
This information actually makes me wonder if the nausea and vomiting is causing this, or if it's a symptom of another issue. Now we have this low back pain. Well, wait a minute, where's that coming in? What does that mean?
That could be caused from the dehydration too.
Absolutely. Or he could have a kidney infection, right? A pyelonephritis can have pain right back in here. Or does he have a kidney stone that's stuck in there and he's actually having kidney problems from a kidney stone not being able to drain the urine? So he does have a history of hypothyroidism, so nailed that. But that makes me think severe hypothyroidism, otherwise known as myxedema coma, up the list for sure. So let's put everything together here, right? So he's got hypothyroidism, he's got depression, he's had episodes of hyponatremia in the past, which is really interesting, and you might not connect those things together. And his skin is super bronzed. So all of these things kind of put together, I suspect that he maybe has something like an undiagnosed case of Addison's disease with crisis.
I always think of President Kennedy.
President Kennedy, absolutely. Also referred to as bronze diabetes.
Okay. Addison's disease. Honestly, I remember reading about it, and then President Kennedy had it, and that's about it.
Right, so it was named after Thomas Addison, who was a British physician, and he described this in like 1855. And basically, it's a chronic insufficiency of the adrenal glands. So everything you think coming out of your adrenal glands just isn't coming. So you have decreased secretion of glucocorticoids, possibly your mineral corticoids, right? We know your mineral corticoids deal with salt. Glucocorticoids deal with your glucose. These patients oftentimes have fatigue, weakness, chronic abdominal pain, nausea, vomiting, weight loss, skin hyperpigmentation. Sound familiar? So some causes of this, right? So there's primary adrenal insufficiency. So this is where your body actually, in a typical autoimmune process, attacks something. And in this case, it would be the adrenal glands. So it would make them non-functional. Or tuberculosis. Still happens. You can get tuberculosis in your adrenal gland, which makes it non-functional. So acute adrenal insufficiency is slightly different. In this case, the adrenal stops producing hormones, producing, but it's not a primary adrenal cause. So it's from something outside of it, right? So it could be something like people that are on chronic steroids. Their adrenal gland is chronically suppressed because the adrenal gland senses all the steroids in there, so it doesn't make as much. And so then all of a sudden, if you take those steroids away and your body needs to respond with a stress, well, your adrenal gland's not able to respond necessarily. And then there's something called Waterhouse-Friderichsen syndrome. And this is generally, you get a Neisseria meningitidis. So this is a pretty nasty bacteria. This is the one that typically causes meningitis, but it can also get into your adrenal gland and cause a lot of trouble there. Your pituitary gland, right? We know that the pituitary from up here sends signals down there to put stuff out. Well, if your signal ahead of you is not working, then this doesn't get to work. So what if you could have totally normal adrenal gland, but if you're not getting the notification that, hey, we need some glucocorticoids that's coming from your pituitary, you're just not gonna get it.
So it could be a pituitary gland problem.
It could even be a pituitary gland problem. And then tertiary adrenal insufficiency is associated with the actual whole hypothalamic pituitary axis, so damage within that axis somewhere. And we're not going to go into all of that. So adrenal crisis, right? How do you define this? So it's acute deterioration in health status. It's associated with hypotension, usually a systolic less than 100, or relative hypotension, right? If they run a blood pressure of 180 and they're now 140, right? They're relatively hypotensive as compared to usual. And that's usually about more than 20 millimeters mercury lower than what they're usual. Usually there's a reason why this happens, right? They just had a recent illness, they had a child, right? That's a big stressor on the body. Significant emotional distress, though. Maybe they lost their mom last week or they had the death of a child. Like, these things can definitely affect you physically. Or, like I said, if they're on chronic steroids and somebody stops them, they can get into some pretty...
So it seems to me, and correct me if I'm wrong, if it's just a lot of basically steroids in your system that is causing a lot of these issues.
It can be. That's definitely one of the causes, for sure. Okay. So the normal mechanism, right? You have the hypothalamus, pituitary adrenal axis. So in Addison's disease, in adrenal crisis, you see the adrenal glands not able to respond at all. So you don't get aldosterone, right? So aldosterone comes out of there and helps deal with the sodium. That's one of those glucocorticoids. So you don't get any sodium reabsorption. you don't get any potassium excretion, and you don't get any water reabsorption, right? So sodium goes down, potassium goes up, and you're hypovolemic. And then let's talk about the cortisol, right? Same comes out of the adrenal gland also. So that actually, the cortisol has a lot to do with your immune system. That's part of the reason why your body increases the cortisol under stress, is it helps your immune system. Well, if your immune system's not working as well, then you're definitely more susceptible to things. And then you have increased metabolism from this, right? So increased illnesses, weakness, fatigue. So the glucocorticoids, which is cortisol, and those, they have a permissive effect on how the adrenergic receptors in the heart work. So it actually has cardiac effects. And without the glucocorticoids, the catecholamines can't exert their full effect, right? So like they're usually more like kind of like speed. And without the glucocorticoids, they can't speed things up like they normally would. So consequently, during an adrenal crisis, patients often have hypotension, right? Because you can't actually tighten down those vessels because those things aren't working. And in severe cases, they may actually be in profound shock. And they may not be responsive to fluid resuscitation. And even scarier, they may not be responsive to vasopressor therapy. But like everything in endocrine, and you'll hear us say this a lot, we don't quite know the entire mechanism of action for that.
So is this a common condition, and what factors really do we have to consider?
So Addison's disease is not very common at all. It only affects about 1 in 10,000 people, which is a pretty low. And then adrenal crisis, even less. So that's 1.5 to 2.8 out of 10,000 people. And that's people with Addison's disease. But it is still seen more common, right? Adrenal crisis, but we see a lot of steroids that people have, whereas Addison's is less common. But studies estimate that roughly 40 to 42% of people with adrenal insufficiency will have an adrenal crisis. So that's pretty high for those that have adrenal insufficiency, right? Women are much more likely to have this, much more likely to have Addison's disease, and it's usually diagnosed in the 30 to 50 age range. Often associated with other autoimmune diseases, which they tend to hang out together, quite honestly. So if they have hypothyroidism, like that's an autoimmune disease, like maybe something to think about.
So would helping the hyperkalemia help in these people?
Yeah. So you're going to do the normal treatments, right, for your emergencies. And hyperkalemia is definitely an emergency, can lead to dysrhythmias. So absolutely. So you're going to, particularly so if you have somebody that has an already known history of Addison's disease or adrenal crisis, like it might lead you more towards that. But you're going to do kind of the usual things. You're going to try your fluids. You're going to try your pressors. If you see changes of hyperkalemia, absolutely address it, because those are things that we can address.
Should we be giving these patients steroids?
So with a documented history of Addison's disease or adrenal insufficiency, yes. Now, the problem, and we don't say necessarily to hit them with steroids because it can confuse it for other things going on. So just if they have a known history of that. And usually if they have a known history, a lot of times they're very well aware of what might be going on.
To basically sum this up a little bit, the adrenals stop working, either primary in Addison's or secondary in adrenal insufficiency. From chronic steroid use or autoimmune dysfunction of the pituitary. So you have low sodium, high potassium, EKG changes due to the potassium, hypotension. So we would suspect that with a recent trigger in this, you would have possibly resistant hypotension.
That's definitely going to make you think of it, right? So if you see a recent trigger and you're doing everything, and this is one of those patients that their pressures are not budging whatsoever, and you've hit them with 5 push-dose epis and Levophed and just nothing is helping, that's the patient that you might be like, hey, this might very well be an Addison's crisis.
Seems to me like, you know, from talking about a few of these cases now, a lot of them have the same symptoms and very overlap. And you know, how are we going to distinguish all of these?
And you're not. The good thing is that the treatment is pretty basic, right? It goes right back to paramedicine 101. You're going to treat your symptoms. A lot of times it involves IV fluids. It involves, you know, treating. If you see signs and symptoms of hyperkalemia, treat it. Obviously, nausea, vomiting, like those are things that we can treat, right? And sometimes you just need more help at the hospital to sort of sort out what this is.
Yeah, okay.